This is for Dr. Klinge. I think the myodural bridge hypothesis is an interesting one. They've proposed for a long time, however, that either myodural adhesions after surgical procedures could cause chronic headaches. And I even wonder whether that doesn't occur post-Chiari surgery as well. So what do you think the role of, like, is it an adhesion different than a bridge? And does adhesion make it even more immobile? So that's one question. And then when Chiari surgery is done, do you actually cut through? Did you say that you actually you take down the myodural bridges?
Yes, so during Chiari surgery, yes, when you go, suboccipitally, you basically release this, the ligamentous portion of the myodural bridges that attach to the dura. We always release them because otherwise we won't be able to fully expose the dura and then so in the duroplasty. So that is part of the procedure. We never really acknowledged that we are actually doing, this, and we affect a part of the myodural bridges. So that's one answer. Of course, my ligamentous bridge is different than a scar, or adhesion. So I would say biodynamically, yes, an adhesion is different. And I think I know the work that you're alluding to. It's like work after suboccipital decompression for tumors or so, yep, where then you have these adhesions, and it just makes it stiffer, and then causes, certainly rigidity of the tissue and can cause headaches. Yes, that is work that's been done. Different from the Chiari surgery, we should not be forgetting when we do the Chiari surgery, and if it comes to the opening of the dura, we sew in the duroplasty, right? And the duroplasty is then the, the part that's driving the CSF flow. So technically there shouldn't be a scar, that are adhesions, because the duroplasty is, the pliable tissue or element that we build in to avoid that. So I think we're talking about two different things, but in fact, yes, it might be that the myodural bridges or the scarring of them is a problem in surgeries in the suboccipital area. Because
there's even some data on post-traumatic headaches, like with whiplash injuries, yes, in fact, where the rectus capitis muscle can become damaged.
Yes.
And maybe actually on imaging, it's actually atrophic. And that they think that might play some role potentially into recurrent headaches after a flexion extension injury.
Yes, exactly.
Other questions?
It's probably for Dr. Rastogi, but anyone could probably chime in if they have any info on this. One thing that caught my eye on your slide was regarding stem cell therapy. I know this is emerging and very early stages, but there's some papers out there on NIH about post-traumatic injuries with Syringomyelia. Is that something that you've used or anybody has used in any type of treatment for a syrinx? And, is that something you think will be progressing in treatment down the road? I know it's a very tough question to answer, but I appreciate your thoughts.
Yeah, so at least from my perspective, what I read or what I come across, I'm not aware about directly related to the Syringomyelia. But there is spinal cord injury patients which has the partial neural injury had shown some discussion. Few of the Centene is one of them, which was trying to do the stem cell therapy associated with this neuromodulation. So I am aware about the combo component, this multimodal component. Maybe one or two patients. I think they reported on that.
Hi. Sorry. For those who are trying to get answers to autonomic disorders and trying to figure out what they have, if they find that a medication has exacerbated symptoms and by the time they had a tilt table test and the symptoms went away, what would you tell doctors to try and get them to keep finding answers to what they have?
So you're saying the symptoms improved on the medication?
Yeah, sorry, I had a medication and I lowered the medication and the symptoms improved significantly, but I think there's still issues.
So the full half of the glass is mission accomplished since your symptoms have improved. I would say if the symptoms continue to improve despite reducing the treatment, whatever the autonomic condition was, it probably was transient, and I would just speak with your healthcare provider and gradually see if you can titrate even further and get off the medication. Because some of the autonomic problems we see, particularly, let's say, after an infection, or after a surgery, or after a stress, they tend to be really, they have a certain duration. It's not always few weeks. It can go up to a year and a half, etc. But many times they resolve, so you really don't need to be on treatment all the time. The other thing, it depends on what the nature of the symptom is, so sometimes when you have autonomic problem and it's what we call multiple domains, your GI, digestive system is not working, but you also have, let's say, POTS, or you have orthostatic intolerance, or the bladder has issues. Sometimes one system or one domain improves, the other domain doesn't improve. So that doesn't mean you have to stay on all medications. Whatever gets better, you can get off, and then you can stay on the others. In terms of testing, we can, most autonomic centers that do testing can target the test to your problem. So let's say, for instance, if you have an issue with temperature tolerance, you get very sick in the heat, etc. There are ways to test your tolerance for that. We can measure your peripheral sweat responses. Some centers, including ours at Stanford, we have what we call a thermoregulatory sweat test chamber. We can put you in a sauna and we measure your body temperature over 8 sites and see how you respond. We dust you with a powder, see how your body sweats and adapts to that. If the problem is mostly, fainting and passing out, we do certain things. Some patients faint in a certain situation. We've had patients who pass out if they move their head abruptly, etc. We have a protocol for that. So, we do vestibular stimulation on you while we're tilting you, see if we can induce the sweating. We have had occasional patients who they pass out, but, colleagues can't tell that they have a seizure or is that fainting. We also have protocols for that. We can do EEG brainwave test on you, baseline, and then we continue to do it while we're tilting you. And actually, we've published results on that. So if it's 1 or 2 domains, there is a way to do it. Obviously, if there are lots of GI symptoms, you have to work with a GI colleague who looks at their motility. But no, many of our patients do not stay on all treatments all the time. You often can end up, titrating them. Some may need to stay on 1 or 2 drugs for a few years. And some may come off, particularly if it was a situational, if you will, dysautonomia. Yeah. Thank you.
Any more questions?
One more here.
Hi, I actually have a couple questions. And as a preface, I am a patient with idiopathic Syringomyelia. So my first question, I was told that I probably have POTS, but that there was no real benefit to doing a tilt test and that I should just, follow the protocol for POTS, increasing my fluid intake, electrolytes, salt. Is there a benefit to actually doing the test and seeing what the results are?
Yeah, so the question was, is there any merit to doing the tilt if you know you have POTS? So one thing we recommend, and you can actually download that from the web, there is the so-called standing test, and some colleagues do that. We have colleagues, primary care physician, or some even cardiology or neurology colleague, they do the standing test on you. You stand for 10 minutes and they do your vitals every minute or so. And that can be a surrogate to the tilt. Studies have compared active standing to tilt, and believe it or not, you would think tilt should be easier on you, because you're on the table and, protected with Velcro straps and so on. But actually, hemodynamically, it turned out tilt is actually more challenging to you. And the reason for that is the tilt angle, the way we select the tilt angle, it reduces a lot the degree of subconscious contraction in your muscles in the leg. While you're standing, your calf muscles and your thigh muscles are really contracting subconsciously. So if your standing test is abnormal and you have POTS, you probably don't need the tilt because you're definitely going to have POTS with the tilt. I think the situation arises the other way around. When you're standing and your heart rate goes up 15, 20 beats and you're not feeling well, you know, you can still try to treat it without without, you know, just using, you know, counter maneuvers, fluid hydration, etc. I think if you're very symptomatic and you need medication, my suggestion would be to do the tilt. Because, you know, with the tilt, not only you get the blood pressure and heart rate, you get the EKG reading. You know, you can we discover sometimes surprises when we do the test. And then you can tailor the pharmacologic management, if necessary, you know, to what we find on your testing. But I think if your standing test is abnormal, you know the tilt is going to be abnormal, and I agree with whoever advised you. You probably just should manage it. Yeah.
Okay, thank you. My second question was for Dr. Klinge. Is it possible that it is also suspected that I have EDS, but I haven't actually been able to see a specialist yet to confirm the hypermobile kind? And if I do, is it possible that the abnormal spinal cord motion caused by hypermobile EDS could cause or exacerbate coat hanger syndrome? Because that is really my primary pain, I mean, almost every day. And if that is possible, does it indicate any potential relief? Is there any potential treatment?
Well, so for now, we assume, you know, that the abnormal spinal cord motion causes neurological symptoms, affecting not only the nerves that come out of the cervical cord, but also the cord itself, because abnormal motion probably causes, you know, blood flow alterations in the biodynamic sense. So I'd like to give you the answer yes, but of course we yet have to bring scientific proof how this relates to symptoms. In fact, that you asked the question, I thank you for that, that's what we're also going to do. You know, we want to also correlate the biodynamic findings with symptomatology. So I have to assume that this is, you know, the culprit for many of the sometimes unexplained, you know, neurological symptoms. So because with that, it would make a lot of sense. The relief is, you know, like, so how are we going to restore spinal cord motion, right? Of course, if we want to strengthen ligaments, if we think it's all like like a spinal suspension problem, how are we going to strengthen ligaments? That is the big picture. I'm not sure, you know, that of course, you know, like instead of strengthening ligaments, that fusion is the answer. I don't think so. Can we strengthen? I mean, there is some therapy out there, like prolotherapy or some injections to strengthen the ligaments, stem cell treatment. I would say, you know, these good stem cells have some capacity to strengthen, you know, like tissue. So I think if we think that spinal cord motion is a relevant problem, then we have to think differently, just as you propose, you know, to relieve it. But that's what I have so far. But I hope this will be work in progress.
All right. Well, thank you, everybody, and we'll see you tomorrow.